Good afternoon. I'd like to welcome you to today's Medical Center Hour. Today's program, The Changing Healthcare Landscape, Preventing Preventable Healthcare-Associated Infections, is a combined Medical Center Hour and Medical Grand Rounds, this time for the purpose of the annual Hayden Farr Lecture in Epidemiology and Virology. Funded by an endowment created by longtime medical professor Jack M. Gwaltney, this lectureship highlights major achievements in epidemiology and virology by distinguished physicians and scientists. The lectureship honors UVA Professor Emeritus Fred Hayden, who is with us today, and the late UVA professor and hospital epidemiologist Barry Farr. This 2017 Hayden Farr Lecture takes a look at transformations wrought in the incidence and successful management and prevention of healthcare-associated infections as a result of certain provisions of the Affordable Care Act. Our lecturer, distinguished medical epidemiologist William R. Jarvis, will focus on how ACA programs have spurred new attention in hospital infections, including approaches that have fostered greater collaboration between clinicians and infection control programs, effected cost savings, and improved the quality and safety of clinical environments and patient care. I'd like to thank the Department of Medicine and the Division of Infectious Diseases especially for partnering with us on this program, and also for all of those involved with the Hayden Farr Lecture. This year especially, we fondly remember Dr. Farr, who died earlier this year, but whose spirit radiantly informs this presentation by his longtime friend, Dr. Jarvis. Here to introduce Dr. Jarvis is Dr. Carleen Muto, one of our present hospital epidemiologists. Carleen.
Good afternoon, everyone, and welcome to the 5th Hayden Farr Lecture. So as you know, this lecture series is to celebrate two great physician leaders, Dr. Hayden, who we still learn from every single day, and Dr. Farr, who has passed away. These two physician leaders have greatly influenced the science of this country and worldwide, and without them, we would really have issues and many different things that would not have come to be. All of the lives that have been saved has been impossible to quantitate. So I was also asked to speak a bit about Barry. Barry was born in Greenville, Mississippi. He never stopped loving Southern food or food culture or people. He majored in chemistry at Ole Miss and went to medical school at WashU in St. Louis, and that's where he met Anne, who was also a medical student there, and he later married her. Together, they traveled to here, Virginia, and they started here as residents, and then Barry did his fellowship in infectious disease and became faculty here. He served as a hospital epidemiologist for 18 years, and he directed the Master's Program of Science in Epidemiology for 11. He retired the William S. Jordan Jr. Professor of Medicine and Epidemiology. During his tenure, he co-authored 167 publications. He had 18 postdoctorate fellows, including myself, and he co-authored 2 books. Unfortunately, Barry's career was shortened and interrupted when he was forced to retire at the age of 52 due to his physical disabilities from multiple sclerosis. Barry put his own spin on hospital epi. He was widely known for his studies and his control of hospital-related infections, particularly multi-drug-resistant organisms. He served as the president of SHAE, which is our epidemiology society, and was the editor of the journal from 2001 to 2004. Of his many gifts, perseverance was one of his best. And as many of you know, Barry never quit. He was one that would just never waver on his position, and it's likely that his unflappable position influenced safety measures across the United States and most certainly played a role in successful reduction of hospital-acquired MRSA in hospitals that implemented the reduction measures. So after retiring, Barry still didn't stop. Because of his MS, he thought there'd probably be better ways to live with MS, and he authored a book with his observations and tips and guidelines as to how to maneuver through that illness. On a personal note, when I think of Barry, I remember enjoying long conversations during my fellowship. His office was in Cobb Hall, and for any of you who ever ventured over there, you would go in and not even realize there could be a man in that office because there was stacks and stacks and stacks of books. And there, way in the back, under a window, sat Barry, likely reading, with NPR playing or some classical music, and it was there where all the work really happened. Barry was also a writer of prose and poetry. He's often quoted literary classics, and during our infection prevention meetings, and still we remember this to today, his IPs really only allow him to do 3 quotes per meeting, or we would never actually finish the meeting. And so as we go through the meeting with Barry, we would hold up a finger and say, "That's one," after he did his first quote. In his last days, he passionately spoke of his life as a child, his education years, his epidemiology career, and his students. And despite his pain and his morphine drip, he still referenced literature and quoted his favorite works. Most of his conversations reflected on fond memories, but he also, in those last moments of his life, insisted that we continue to do his work and all of our work so passionately and keep patients safe. My hope for the future is that we stay strong in our convictions and never surrender to those who attempt to underscore patient safety. For those fortunate enough to know Barry and work with him, you know he was a tremendous mentor, thinker, and had a questioning mind. He has left an indelible mark on patients, trainees, and colleagues, and he interacted with us also intimately. We will greatly miss him and forever love him. It now gives me great pleasure to introduce this year's speaker, Dr. Bill Jarvis, for the Hayden Farr Lecture. Dr. Jarvis, like Dr. Hayden and Dr. Farr, has greatly contributed to the science of healthcare epidemiology and virology. He earned a BS from UC Davis, and he went to medical school at University of Texas. He completed his PEDS training at UT and the Children's Hospital in Los Angeles. He ultimately landed a long-standing career in hospital epidemiology, epidemiology in general, and public health. So he went in 1980 to the CDC as an EIS officer, and he probably never realized he would then spend the next 23 years of his life there, where he was in epidemiology in Atlanta, as well as the director of the hospital infections program. He devoted his entire life to preventing HAIs and still is doing that. He's authored over 400 papers, 65 book chapters, 45 surveillance reports, and his passion speaks to even 40 letters to editors. He's edited 4 books, and not surprisingly, he has more pages of awards on his CV, 4 to be exact, than most people have pages of publications. He spent more than 35 years not only uncovering new and emerging risks in healthcare, but his work is never complete until he figures out the remedy and eliminates the risk in healthcare. His areas of study are wide, and everyone in our department at UV has something that Bill has studied. He's looked at C. diff, MDR, TB, Legionella, MRSA, mycobacterial infections, needle sticks, HIV, foodborne illnesses, but his primary work has centered on infections associated with devices, as well as multi-drug resistance. Bill has done it all. He has trained and mentored hundreds of young epidemiologists. I'm proud to know him and call him my friend, and he and Barry, together with all the other colleagues in epidemiology, have worked on many issues, and they epitomize the primum non nocere. Ladies and gentlemen, Dr. Jarvis.
Carleen, thank you very much. Thank you for the opportunity to be here to talk at the Hayden Farr Lecture. It's really the ultimate honor. And no respect to Dr. Hayden, I'm going to focus my presentation on healthcare-associated infections because that's what Barry and I have spent our careers doing. I consult for a number of companies. This is one of my favorite pictures of Barry. If you look at this picture, you can see the enthusiasm that Barry had for life and his passion for medicine, and particularly evidence-based medicine. And it was my honor and pleasure to work with Barry in a number of positions, including he and I worked as editor and co-editor of infection control and hospital epidemiology when he was having to retire because of his MS, and also as president of SHAE I was president and Barry was vice president and came in after me. So we had a number of professional opportunities to work very closely together. And I think all of us that know Barry know how passionate he was about medicine, but he also was a loving and dedicated husband to Ann Henry and truly loved his 3 children who are now carrying on the legacy. Fred, I won't say anything about because you may have retired, but you really haven't truly retired. As Carleen said, Barry's passion was infectious disease and the prevention of healthcare-associated infections. And specifically 2 areas that he focused a great deal of his research on were the prevention of catheter-associated bloodstream infections and MRSA. So I want to focus my attention on those 2 areas today. If we look at healthcare-associated infections, about 1 in 25 patients that enter your hospital here will develop such an infection. A large percentage of those, 44% of those patients, will be over 65 years of age, and 1 in 9 of those patients will die directly or indirectly as a result of those infections. So these are serious events that have tremendous impact on our patients and our hospitals. You all, much more than I consult now, so I'm not doing as much clinical medicine, are really faced with a dramatically and ever-changing healthcare environment. If we look at that environment, you have the Affordable Care Act that brought in a number of incentives and penalties, including CMS readmission penalties, non-payment for healthcare acquired conditions, and what's called value-based purchasing. This has led to a number of regulatory requirements, reportable metrics. I've already talked to several people about that today. What has to be reported, usually through the CDC surveillance system, that then goes to the Center for Medicare and Medicaid Services. Measured patient outcomes, patient satisfaction reporting, and then evidence-based medicine protocols. And it's provided opportunities, and these include lowering or eliminating readmissions, eliminating healthcare-associated infections, increasing patient satisfaction, and most importantly, improving patient outcomes. If we look at the 3 kind of legs, if you will, of the Affordable Care Act, one is readmission reduction program. This begins by penalizing hospitals with the limit being 1% of their total Medicare payments. Well, if you think of what percentage of your patients are Medicare patients, number 1, and number 2 is what the operating revenue is and profit, it's not that large. And when you take 1% of Medicare, it ends up being a lot. It started at 1% and gradually has increased since then. The conditions initially focused on were COPD, elective total hip arthroplasty, and knee arthroplasty procedures, but they're expanded to other procedures as well. The hospital-acquired conditions component of the ACA has brought tremendous attention to the prevention of these infections, as has public reporting. Started in 2015 as a part of paying for performance, and CMS, which was charged by Congress to identify at least one condition that they would no longer pay for, picked 10 conditions, with 3 of them being healthcare-associated infections. Central line-associated bloodstream infections are actually vascular catheter-associated bloodstream infections, selected surgical site infections, and catheter-associated UTIs. So for those of you that might be interns, residents, or fellows, that's why so much attention is placed on those specific conditions. Again, this has brought a number of penalties that can decrease your overall inpatient payments by as much as 1%. The other thing that you'd note from this, if you look from 2005 through 2014, is that it's not a static condition. It's constantly changing. Bloodstream infections, UTIs, colon procedures and abdominal all kind of started in the 2015-2016 timeframe, but now more focus is being placed on antimicrobial resistance and C. difficile. And then we have what's called value-based purchasing. With value-based purchasing, all hospitals are included, and a percentage of their Medicare payment is taken away at the beginning of the year, and then everybody is compared at the end of the year, and it's divided into thirds. The lowest third in terms of performance loses that money that was taken away. The middle third gets back what they started with, and the top third gets a bonus. This started at 1% of terms of reduction, and now is up to 2%. So it's gradually increasing. What is the impact of all of this? Well, your hospital could lose 2% to other hospitals. That ends up being a huge amount of money. How are you scored? You're scored in two different ways. One is, how do you compare with yourself over time? And then how do you compare to other hospitals throughout the country? And CMS was very generous at the beginning of this by allowing you to basically choose whichever one you did best in. Another part of this that's very interesting is what's called Medicare Spending Per beneficiary. You would think that if I had a coronary artery bypass procedure here at UVA, it would not be that different in cost from UC San Francisco or from a private hospital in Brownsville, Texas. But the fact of the matter is tremendously different. And so part of this is looking at Part A and Part B claims from 3 days prior to admission to 30 days after hospital discharge, and looking at all costs, with the ultimate goal to standardize costs for different procedures across the country. As I said, this is a constantly changing target, and that certainly presents a number of challenges for our healthcare systems. As you can see on the left-hand side here, different colors for clinical processes of care, patient experience, outcomes, safety, and efficiency. And what you see at the very beginning, there was a lot of focus on clinical processes of care and outcomes. And as we've moved to 2017, you're starting to see more attention being placed on safety and efficacy. The bottom line is these can have a tremendous impact on your bottom line. 2% for value-based purchasing, 3% by readmission reductions, and 1% for hospital-acquired conditions. So 6% of Medicare payments could be lost. So given that, let's look at some of the progress that's been made in two specific areas, beginning with prevention of vascular catheter-associated infections. If we look at the Society for Healthcare Epidemiology of America recommended practices, there's what's called an insertion bundle and a maintenance bundle, because we know that the pathophysiology of infections associated with insertion are different than with maintenance. The recommendation is to use a checklist to obviously perform hand hygiene before catheter insertion, to avoid femoral lines, because we know from randomized controlled trials that femoral lines have the highest rate of infection, followed by internal jugular, with subclavian having the lowest rate of infection. Having a cart or kit, because we know that when you're inserting a catheter, if you have to remember all the elements and then go hunt and find them all, you're probably not going to do it. Certainly wasn't the case when I was in training. But if you have a kit where you open it up and everything is there, you're likely to use it. Using maximal barrier precautions, and then chlorhexidine with alcohol for skin prep. For catheter maintenance, chlorhexidine bathing of ICU patients, use of antiseptic or antimicrobial impregnated catheters, use of a chlorhexidine impregnated disc or biopatch, and use of antimicrobial locks. So these are the insertion bundle elements. Let's look at the data that led to those. First of all, this is just an example of a checklist, but it gives the different elements, what the level of recommendation is, what it specifically is to be done, and then whether it was done or not. And the value of collecting data on processes is that you can then see what % of clinicians are complying with those processes, because we know if all of the evidence-based processes are applied, that the risk of infection is dramatically decreased. So this is just an example of looking at the different physicians who are inserting these lines and whether they're using the appropriate skin prep, maximum barrier precautions, etc. Hand hygiene. We all know the importance of hand hygiene. I'm sure I can ask Carleen what your hand hygiene rate is. She'll tell me some number that's been obtained by doing visual observation. Well, I will tell you, visual observation is garbage. Been proven by both electronic and by video monitoring. We did a study in ICUs in Northern California where the visual monitoring hand hygiene compliance rate was 60%. We have videotape for an entire year. We can pick any day, any time. We have automatic ways of actually measuring it, and the compliance was at best 11%. If we looked at, did you do hand hygiene? How much agent did you put on your hands? How long did you apply it? And did you apply it the way that WHO recommends? Compliance was 0. So we have a lot of work to do there. This is an example of a catheter kit where everything is present. You open it up and everything you need is there. We have a number of studies that have looked at povidone iodine versus chlorhexidine or chlorhexidine with alcohol for skin prep. This is a meta-analysis published a number of years ago that show that chlorhexidine with alcohol has a lower rate of infection than associated with povidone iodine. A more recent randomized controlled trial of povidone iodine with alcohol versus chlorhexidine with alcohol still showed chlorhexidine with alcohol was superior. But it needs to be applied correctly. At least 30 seconds for application and 30 seconds to allow it to dry. What about maximum barrier precautions? This is actually the only randomized controlled trial looking at it. It's at MD Anderson Tumor Institute with high-risk oncology patients where they did everything that I mentioned except maximum barrier precautions and then added maximum barrier precautions to that. And you can see in white is total infections, in yellow is what they called early infections, and their early was very broadly defined as within a month, and both significantly decreased when they applied maximum barrier precautions. This is what maximum barrier precautions looks like. The inserter is cap, gown, mask. The patient is covered from head to foot so that if you drop the syringe, you drop the needleless connector, it falls onto a sterile field. The only area that's open is where you're going to insert that intravascular catheter. We're treating the insertion as if it's a surgical procedure. Now, if you think about it, we've put a lot of attention on insertion bundles. Institute for Healthcare Improvement, CDC, et cetera, have really focused attention on insertion. If I were to ask you, how long does it take a surgeon to insert, or a critical care specialist to insert a central line? How long do you think it would take? Well, if they're halfway proficient, probably about 15 minutes. What's the average duration of a central venous catheter in most ICU patients? 5 to 6 days. So if you think about it, the insertion accounts for less than 0.1% of the time that that catheter is in place. And that's why maintenance is equally important. With minimizing the catheter site bioburden by using a chlorhexidine impregnated dressing, making sure you pick the right device. I think every hospital I've ever been in, anesthesiologist always put in a double or triple lumen catheter in the internal jugular. It's like they're making cars. Every patient gets the same thing. Well, every patient doesn't need a triple lumen or a double lumen catheter. And certainly we know internal jugular lines are great when they get to the ICU, because what happens? You intubate the patient and they sit there drooling down onto that internal jugular line. Antiseptic or aseptic manipulation of the catheter has been called scrub the hub. We've done studies on needleless connectors, including here at UVA. Using antibiotic antiseptic locks and antibiotic or antiseptic impregnated catheters. We need to keep in mind the microbiology of the skin. 80% of the resident bacteria are in the top 5 layers of the skin. 20% of those organisms are in biofilms on hair follicles and sebaceous glands. So if I gave you a bucket of chlorhexidine with alcohol and you sat here scrubbing my arm for the entire time of my presentation, my arm would still not be sterile. We need to keep that in mind, because those organisms, once you finish applying that skin antiseptic, it's like you shot off a gun at a race. They start growing again. And usually by 18 to 24 hours have reached the same level that they were at before you applied that skin antiseptic. We also need to keep in mind that a microbial density of organisms is different in different locations, and explains, at least partially, why femoral lines have the highest rate of infection. This is just taking a swab where that little black box is of the antecubital space and placing it on a blood agar plate, and you can see 10 to 20 colony-forming units per cubic centimeter. If you do the same thing, but you do it in the subclavicular area, it's almost too numerous to count. It's about 10 to the 3, 10 to the 4. And if you would do the same thing in the groin, it would be 10 to the 5, 10 to the 6. So think of that. If at least 20% of those organisms remain, 20% of 10 or 10 to the 2 versus 10 to the 6 is a very different number. This is a randomized controlled trial by Timson and colleagues in Paris, France, at both general and academic medical centers and ICU patients, looking at 2 things. One was the use of a chlorhexidine impregnated sponge dressing at the insertion site, and the second was changing the dressing at 3 days versus 7 days. I know this is a bit busy slide, but if you focus your attention mostly right over here, you can see that the first thing is in controls, the catheter-related bloodstream infection rate is really pretty low. This study was published in 2009, actually was done in 2006 and 2007. So that rate at that time was much lower than the CDC surveillance system medium rate. And yet when they used this chlorhexidine impregnated sponge dressing, and they were doing everything in the study that I told you about in the insertion bundle, except they were using povidone iodine with alcohol rather than chlorhexidine with alcohol as a skin prep. So that could be one slight criticism of the study. But what you see here is a dramatic, almost 70% reduction in collapsy rate, a decrease in colonization, and a decrease in overall line-associated infections associated with the use of this impregnated disc. This is a meta-analysis looking at antiseptic and antimicrobial impregnated catheters. There have been a number of such meta-analyses that basically show that you get about a 40-45% reduction in central line-associated bloodstream infections when you use impregnated catheters. Particularly has been recommended in patients who are going to have catheterization for more than 5 days. So given all of these interventions, are there any data to suggest that if you actually apply them, that they improve patient safety and reduce costs? Well, probably the most famous is by Peter Pronovost and colleagues from Johns Hopkins. They did the study initially at Johns Hopkins University and then expanded it to the entire state of Michigan, where they recruited at least one ICU from as many hospitals as possible in Michigan, 108 hospitals, ended up ultimately with 103 ICUs, almost 2,000 months worth of ICU data, almost 400,000 patient catheter days. And if we look at the mean CVC BSI rate of per 1,000 catheter days, first of all, their baseline rate in all these ICUs starts out at fairly low, at 2.7 per 1,000 catheter days. But look at that number at 3 months, 0. The median rate in 103 ICUs was 0. They focused only on insertion bundle. So if you have patients that were in the ICU for a shorter period of time or only had a central line for, say, 3 days, they probably were at very, very low risk. But I think part of the reason why they bounced back a little bit by 16 to 24 months was the failure to include a maintenance bundle as well. Some hospitals did, some hospitals did not. Some applied some of the maintenance bundle I talked about, some applied more of it, but they didn't collect that data, so we really don't know. But it certainly showed that use of an insertion bundle could dramatically decrease the rate of central line-associated bloodstream infections in intensive care unit patients. These are data from the CDC and their surveillance system, and they compared CLABSI rates in intensive care units in 2001, where there were no insertion bundles being applied in most ICUs across the country, compared to 2008 and 2009, when almost all ICUs were applying them. And you can see that the number of CLABSIs decreased from 43% in 2001 in intensive care units down to 25%. Literally 55% reduction in central line-associated bloodstream infections in ICU patients across the entire country. The other thing you noticed is that now the ICU numbers are very similar to the non-ICU numbers, and part of the reason for that was that at the time, even as late as 2009, 2010, these interventions weren't being applied to patients outside the ICU. An even bigger problem was the group that we know has the highest rate of bloodstream infections. Hemodialysis patients had the highest number of bloodstream infections. So what we've seen from about 2010 to 2017 is pushing of these interventions outside of ICUs and to outpatient and hemodialysis centers as well. Pretty dramatic results. In 2009 alone, 25,000 fewer CLABSIs, of almost 60% reduction in the entire country between 2001 and 2009, 6,000 lives saved, over $414 million in potential excess healthcare costs saved in just 2009. If you look at the entire time, 2001 to 2009, over $1.8 billion. So tremendous improvement in patient safety. I have no doubt that if I had gone into an intensive care unit here at UVA when Barry was here, or even as late as 2001, and said to the intensivist, I bet you can achieve a 0 CLABSI rate in this ICU, I would have been laughed at and thrown out of the unit. Wouldn't have believed me. And yet, critical care specialists really carried this program forward across the country. And I think they deserve a lot of credit for taking responsibility and accountability for their patients and achieving these results. And we should mandate that from all ICUs and now outside of ICUs throughout the country. So let's move to the other area that I think probably was the highest priority for Barry in terms of prevention, and that's prevention and control of MRSA. Carleen knows this document quite well. She's the first author of this. This is when Barry was president of SHAE, and he felt there really was necessary for the Society of Healthcare Epidemiology of America to push prevention and push evidence-based medicine, and led to the development of this guideline for the prevention of nosocomial transmission of multi-drug-resistant Staph aureus and enterococci. And the major recommendations were to conduct a risk assessment to identify who are the patients at greatest risk for MRSA infections, to then do active screening, whether that be by culture or by polymerase chain reaction, of those high-risk patients, to then place those MRSA positive patients, whether they're infected or they're colonized, in contact isolation, do hand hygiene, and then with a little bit less emphasis, antimicrobial stewardship, primarily because antimicrobial stewardship may have been important way back in the 60s, 70s, and maybe even early 80s in the emergence of MRSA, but really the problem after that was more person-to-person transmission rather than antimicrobial use. And then decolonization of selected MRSA patients particularly has been shown to be effective in surgical patients such as cardiac surgery, orthopedic, and neurosurgery patients. These are data published in 2015 from the United Kingdom. If you were in the United Kingdom from about 1970s through early 2000s, what you would have seen was the rate of MRSA and MRSA bloodstream infections increased every single year. There was not a single year where it went down. And there was total disbelief by most infectious disease colleagues and microbiologists in the UK that MRSA could be controlled in the United Kingdom. Excuses were the hospitals are old, nurse-to-patient ratios are too high, hospitals are dirty, et cetera, et cetera. And it wasn't until the Blair administration came into office and mandated that active surveillance testing be done. And you'll notice this blue is voluntary reporting and the red is when active surveillance testing was done. And not surprisingly, more MRSA is detected when you do active surveillance testing. The other thing you'll notice, and there were a large number of other things, one of the probably most powerful was systems of hospitals and regions there are called trusts. And there's a president or a chairman or head of the trust. And one of the things the government said was, well, if you are the head of the trust and your rate does not achieve our goals, which is about a 50% reduction in 4 years, your hospital will get reduced reimbursement and we'll consider firing you. That did catch the attention of CEOs and hospital administrators. They implemented this program, and for the first time in the United Kingdom, the rate of MRSA decreased. In fact, that rate target for 4 years, which is achieved in 2 years. There have been a number of other studies that have been done since then. This is a study in critical care medicine in 2015. It's a quasi-experimental study with an interrupted time series design. But what's interesting about it was they had no intervention. They then implemented the Shea compendium recommendations. Then they took them away, and then they put them back. So in period 1, in red, there's no intervention. So decolonization was only for MRSA clinical patients when indicated, and they did do contact isolation, which was recommended by CDC. And then in period 2, they do active surveillance testing, decolonization of carriers in the SICU at the time of admission, and also did contact isolation. Then in period 3, they go back to their baseline, and then in period 4, they add the interventions again. And what you see here is when they do the interventions, the MRSA goes away, shown here, and again goes away. So for those that like to say, well, it's not a randomized controlled trial, there's reversion to the mean, well, it may be reversion to the mean, but then it's coming back again. And most of the studies that have been done, actually, that are observational studies or before-after studies, have also looked at MSSA, methicillin-susceptible Staph aureus, where the interventions haven't been applied. And you would expect if it's reversion to the mean, they both would revert to the mean, and the MSSA rates have not decreased. This is a little different study by Robichek and colleagues out of Evanston Hospital, actually 4 hospitals in Evanston, where they did what the Shea recommendation said to do, a risk assessment, and identified a number of different patient populations that should be screened. But they found that it was too complicated, or they thought it would be too complicated for the nursing personnel to identify this group, but not that group, and make sure they got the testing done. So they decided it's just easier, we'll just do universal testing. So they implemented universal testing and saw a significant reduction in the prevalence density of MRSA, with the percentage of exogenous MRSA falling from 48 to 33%. And the intervention was estimated to reduce healthcare-associated infections by almost $9 million. This is showing over time a significant decrease. And this hospital has continued this intervention. They've expanded it to their long-term care facilities as well, and have maintained a decreasing rate of MRSA in their hospitals. And they concluded that the introduction of universal admission surveillance testing for MRSA was associated with a large and progressive reduction in MRSA during admission and 30 days after discharge, and had been sustained in 2008 for 4 years and has continued until now. Probably one of the largest interventions has been done by the VA system, published by Hayden and colleagues in 2011. They introduced what they call the VHA MRSA bundle, but it basically is the same as the SHA compendium recommendations of active surveillance testing on admission, transfer, and discharge, hand hygiene, contact precautions, and they included this cultural transformation. They began this initially just in the ICUs in 2006. As you'll see, it was successful, so they expanded it hospital-wide in 2007, and then more recently have expanded it to their long-term care facilities as well. And both in the ICUs, shown here in orangish color, and the non-ICUs, both saw a dramatic and significant, statistically significant reduction in MRSA. Interestingly, as a part of the ACA and a part of the Department of Health and Human Services getting involved in trying to coordinate activities for HAI preventions across the different federal agencies, one of the things that they did was came out with goals. The numbers were somewhat picked out of the air, but what you can see here on this slide is basically in green or red is whether the initial goals were met or not. CLABSIs, nationwide, a 46% reduction. And MRSA bacteremia, 8% reduction. C. difficile infections, colon infections, SSIs in general have not been as successful at meeting those goals, although they are slightly reduced, whereas counties have increased. I think one of the things that Barry really focused his attention on was the importance of the hierarchy of medical evidence and the importance of doing studies up here, randomized controlled trials, systematic reviews, in addition to cohort and case control studies, and that the evidence should be unbiased, it should be factual, kind of like the issues that we're dealing with now with fake news. We need to be critical at looking at studies and evaluating them, but if you have solid medical evidence, it should be applied. I want to end by showing a picture of Barry toward the beginning of his career and toward the end. And as Carleen said, Barry retired because of the onset of disability with multiple sclerosis. And Barry, being the passionate investigator that he was, did not let that opportunity pass by. He studied his illness as time went on. He studied doing different things to try to prevent complications from occurring as a result of that disability, and ended up shortly before his death publishing this paper, Multiple Sclerosis, Coping with Complications. And I think this should be mandatory reading for all departments of neurology, all clinicians who work with multiple sclerosis patients, and actually probably be given as gifts to patients with multiple sclerosis, because it has many, many kernels of knowledge that only Barry would appreciate that will help these people avoid the complications, particularly infectious complications, that can lead to their demise. So in conclusion, Barry was a passionate advocate for the implementation of evidence-based medical practices and the prevention of healthcare-associated infections. He would be excited by the progress in the prevention of these infections, particularly CLABSIs and MRSA, although he also would be very frustrated that it's taken us so long to get to this point, and that we should be aiming for zero. We should have a zero tolerance for healthcare-associated infections. Can we prevent every one of them? Probably not, but that should be our goal. The changes in the healthcare system are highlighting pay for performance and the use of outcomes rather than just the frequency of events. Accountability is essential for preventing healthcare-associated infections. I know those of infection control talk about infection control as everybody's business. Well, that is so true. Carleen's not routinely, in her day-to-day job as a hospital epidemiologist, intubating patients, placing IV lines, doing surgery. But she and her department have the knowledge of how to prevent those infections from occurring. And so their job is to teach the rest of the clinical staff what those interventions should be, and then administration should be holding us all accountable for applying them. Senior leadership is accountable for providing adequate resources. If we look at mandatory reporting through NHSN, all the different elements I told you about with the Affordable Care Act, they put tremendous burden on infection control departments, and in most hospitals throughout the country, it has not led to an increase in the number of people actually collecting that data. And we need to understand that surveillance is critical, but it's taking that surveillance data, analyzing it, and then determining where further interventions will be useful. And I think if we can do that, working together, clinicians with the hospital epidemiology department, and preventing those infections from occurring, we will be upholding the principles that Barry held so dear to him during his life. Thank you very much.
Thank you so much. We have a good amount of time for comments and questions. And we'll have a couple of mics here that we can bring to you, so you can be on the video recording and heard in other locations as well. The floor is now open for questions, and I would ask that when you have the microphone to make a comment or ask a question, please do identify yourself and before you ask your question. So the floor is now open.
Bill Petrie from EVA. A question about MRSA. Now that the community-acquired MRSA is so common, does it still make sense to try to limit MRSA transmission in the hospital?
Excellent question. My answer to that is yes, even more so. And it's interesting, if you look, for instance, in California, you have two very good examples of taking a proactive approach versus taking a passive approach. At UC San Francisco and San Francisco General, the attitude has been, MRSA exists, it's already here, it's already endemic, who cares? And what we've seen at San Francisco General is that the community-acquired strain is transmitted just as readily as the hospital-acquired strain. And now at San Francisco General, the community-acquired strain is the most prevalent hospital-acquired strain. In contrast, if you just get in a car and drive for about 20 minutes down to Stanford University, they've taken the opposite approach. That MRSA is bad. It doesn't matter if it's hospital-acquired or community-acquired. Both of them cause bad disease, and we want to prevent them. And they have taken a much more proactive approach. And as a result, the hospital-acquired strain remains the primary strain there, and they have not seen a tremendous increase in their MRSA.
Bill, thanks so much for your talk. I wanted to get back to the points you made about the impact of the ACA on trying to improve certain aspects of infection prevention. And I was wondering two things, really. In the various Republican versions, which have not yet been approved and trying to repeal it, did they address these very important issues or not? What are the changes in there that relate to infection control? And then also in the discussion about trying to improve the ACA, what would you recommend in terms of things to be done differently to reduce hospital infections?
Well, I think it's actually very interesting that I think both, certainly the Democrats and the Obama administration did not do a particularly great job of highlighting all the different elements of the ACA. I'm talking about just several parts that particularly affect hospitals in terms of infection control. But there are so many different aspects of the ACA that really was trying to push away from just paying by volume and starting to focus on outcomes. So I think they could have done a lot better job of educating the population in general about all the different aspects. And some are good and some are not so good. You know, I think particularly the area of electronic medical records probably oversold the value of that, because if I come today to UVA and have cardiac surgery and then I go back to Oregon and I get admitted to, say, University of Oregon Hospital with a complication, you have an electronic system and they have an electronic system, but they don't talk to one another, so what does it matter? Whereas for the VA system, for instance, where most veterans don't go to some other hospital, they go to a veterans hospital. So there, it is very useful. So I think there were some pluses and some minuses. Like I can tell you, many clinicians tell me, particularly if they're older like me, that when electronic medical records came into play, it really took them away from their patients. They sit there the whole time doing this rather than actually talking to their patients. In terms of repeal and replace, I don't think any of us have any idea what impact it would have on all of these different elements. But I think one thing we probably have a pretty good idea of, and that is that the amount of funding that would go for infection prevention would drop dramatically. Just to give you a sense, this year, CDC is giving more than $100 to $150 million to states, that hopefully some of that at least, if not most of it, gets to hospitals for infection prevention and healthcare epidemiology that before ACA did not exist. It would not have happened. So the amount of funding that's gone from the federal government into this area has dramatically increased. And I think we can probably pretty sure that if repeal and replace is successful, a lot of that money will disappear.
Hi, that was great, Bill. Thank you so much. So I'll only do 2 questions, one CLABZ and one MRSA, since there are others I'm sure that have questions. So the first is about the maintenance bundle for prevention of a CLABZ. And so there are companies now that sell caps that have alcohol impregnated, and so like the Curos or the swab cap. And the idea is that you leave that cap on, and then they tell you that you don't have to scrub the hub. And so I just wanted to get your comment on, do you think that is equivalent to scrubbing the hub, or what would your recommendation be?
Well, I think a couple of things that raises, one of which is that notice in the maintenance bundle or the insertion bundle, nothing is said about needleless connectors. And we know that virtually all of our patients have needleless connectors, and some are defined well, others aren't designed so well, that the risk of contamination is there, and that's where the scrub of the hub has come about. If you look at the studies, and I know the more recent Shea compendium actually makes a category 1A recommendation for alcohol caps, despite the fact that if you look at the data, there's not a single randomized controlled trial. At the time of that recommendation, there were 4 studies. None of those studies were hospital-wide. 2 of them were outbreaks. 2 of them did not reach statistical significance. And one of the common themes in all of them was getting compliance above 60% was very, very difficult. I think it really depends on the connector, and we really need to have connector-specific disinfection studies and recommendations, because there's some connectors that are very well designed, they're clear, straight fluid path, have a very flat surface for disinfection, that probably 5 seconds of alcohol wipe and they're fine. Many others don't meet those criteria and probably need longer periods of time. One of the problems first of all, alcohol caps are very, very positive development in terms of nursing personnel. They love it because it saves them time. Anything that saves a nurse time, they like. The problem is, as you said, they think that if you put that cap on, you don't need to ever disinfect. So I can come to the patient with 5 syringes, take that cap off, put a syringe on, another syringe, another syringe, another syringe, put a cap on, walk away. No, you need to be disinfecting in between those. And you also have to look at the cost. The caps are pretty expensive, and is it better to have a lousy needleless connector and use caps, or get a much better connector and not use caps?
Thank you. I don't like the caps. I don't care about them. I mean, if you use them, fine, but I still think you need to scrub. As far as the MRSA, so as you know, there are two schools of thought, and the one school of thought is to, instead of doing the more vertical interventions for MRSA, is to do the horizontal. And so kind of the idea is if you wash your hands or perhaps couple that with bare below the elbow, that you'll never have to worry about the organisms like multi-drug resistant, Staph aureus, or others. And so I just wondered if you can comment on that.
Yeah, I think this whole argument of horizontal versus vertical, if you look at when you and Barry came out with the HA compendium, around that time we started seeing a group within the hospital infection community who were kind of anti-active surveillance testing and trying to come up with a number of reasons why. So it's too costly, it requires too many isolation rooms, et cetera, et cetera. The excuse kept changing of why we can't do it. That ultimately led to this argument of horizontal versus vertical. But if you look at the people who make that argument, they need to be logical. If you're going to say, I'm not going to do active surveillance testing, contact isolation, hand hygiene for MRSA, I'm going to do all these horizontal interventions, well, then you should do horizontal interventions for TB, for all the diarrheal diseases, for all the other antibiotic-resistant organisms. You all have been dealing with KPCs. Let's do horizontal. Forget all the screening stuff and placing them in contact isolation. You don't need to do that. It makes no sense. Also, none of the people that have made the argument for horizontal, to my knowledge, have published their data showing that they actually are successful at reducing these infections from occurring, and certainly have not done a randomized controlled trial in any way. So to me, it's just kind of a bogus argument. If you're going to do it, you got to do it all the way. Yeah, I'm not arguing, and I think the data for CLABSI show you that horizontal interventions are very useful. And for CAUTIs, CLABSIs, SSIs, VAP, I think all of us would argue for horizontal interventions. But the fact of the matter is, what are you going to do for C. difficile? I'm afraid for C. difficile, there are certain things that you need to do that are specific to C. difficile. Antibiotic exposure is important for C. difficile. Environmental disinfection is important for C. difficile, more so than perhaps with MRSA. So if you pick some horizontal approach that's going to apply to all antimicrobial resistant organisms, I don't think it's going to be very effective.
Hi, I'm Robert Epstein. I'm retired chair of anesthesiology. You took a knock on the specialty to some degree, and I wondered at the time whether you were referring to ICU-placed catheters or operating room catheters, which may be restricted by the requirements of surgical field exposure. And just in passing, I will remind you that Peter Pronovost, who you spoke well of, is an anesthesiologist at Hopkins and a recent election to the National Academy of Medicine.
Oh, absolutely. No, my comment was primarily to insertion of central lines in operating rooms. And I think part of the problem there is that at least many anesthesiologists that I speak to about, why did you put that triple lumen IJ line in when there's a very nice randomized controlled trial by Parenti and colleagues looking at femoral versus subclavian versus IJ, showing that IJs have the second highest rate of infection. And the argument that I get is, well, number one, it's easier to do, it's faster, it works best in the operating room in terms of visual field, and they don't get an infection here in the operating room. Well, that may well be the case, but if that patient then goes to the ICU, which many of them do postoperatively, and they're sitting there, two things. One is the dressing. If you just think of gravity, if you put a dressing like this, what's going to happen? Dressing is going to be pulled down. So the likelihood that you're going to have a wet dressing from respiratory secretions, the likelihood that it's not going to stick well is great. So why not put in a very distal axillary line instead of putting an IJ line in? If ultrasound guidance issue, well, two things. If I said a subclavian rather than a distal axillary, the argument that I'd get, well, there's a higher rate of pneumothorax. Well, I guess I'd make two arguments. One would be, well, if you do place a subclavian but you're using ultrasound guidance, the risk of pneumothorax is significantly decreased. And if you don't want to do that, or if you want to just put in a distal axillary, the risk of pneumothorax is almost eliminated.
Thank you. We're out of time, but I would like to thank you on behalf of all of us and for the Hayden Farr lectureship. Barry would have loved this. Thank you so much.
Thank you.
We invite you to join us next week. We have the Honorable William Hazel, Secretary of Health and Human Resources for the Commonwealth of Virginia, coming to give our Richardson Memorial Lecture of the School of Medicine. He's going to be talking about, it's really the third in our series of programs about the opioid crisis, and this will be looking at transforming Virginia Medicaid's addiction and recovery treatment services. Also responding to talk about the local situation will be primary care physician Monad Carney and two people, Marna Bentley and Rebecca Kendall from Region 10. So please join us then. And again, please thank Bill Jarvis for a wonderful talk. Thank you.